This conference will now be recorded.
So, good evening. Welcome to the class on behalf of Gleams Academy. We are going to start for today's GTG. That's on cervical cerclage. Amazon Fresh Super Value Days. So, let me share the presentation with you and yes. So, let's start. Cervical cerclage, it is an updated green top guideline. This is the second edition and it has been published in 2022 itself. Um, the key recommendations of the guideline are a woman with singleton pregnancies and three or more previous preterm births should be offered a history indicated cervical cerclage. So I'm just going through the key points so that we can and later on we can read it completely thoroughly, okay, in the guideline itself. So, women with the singleton pregnancy with the history of spontaneous second trimester miscarriage or loss, or the preterm birth, who have not undergone a history indicated cerclage may be offered serial sonographic surveillance, as those who experience cervical shortening may benefit from ultrasound indicated cerclage, while those whose cervix remain long have a low risk of second trimester loss. That means they are saying that if a patient is having three or more previous preterm birth and this time she is having a singleton pregnancy, we can offer her the benefit of history indicated cervical cerclage before even doing the ultrasound assessment of the cervical length. So, three or more losses are the direct indication of the cervical cerclage. Okay, now they do not term the cervical cerclage as the single one or as a variable. They say it is either history indicated cervical cerclage or ultrasound indicated cervical cerclage, or it is an emergency situation cervical cerclage. Okay, so like this they classify the cerclage rather than naming it a cervical cerclage. And second thing is, they are saying that if a woman who is having only one spontaneous second trimester loss or preterm birth or two second trimester losses, I mean less than three, okay, in them we have to offer them, we should offer them serial surveillance by ultrasound. And if there is cervical shortening, that means less than 2.5 centimeter cervix, then ultrasound indicated cerclage can be offered to that woman. Okay. And then third number is singleton pregnancy with no other risk factor of preterm birth. Insertion of cerclage is not recommended, even if you have found a incidentally identified short cervix. So there are situations we should remember that if a woman has three or more previous preterm birth, then a woman should be offered three or more previous preterm birth, history indicated cerclage. Um, History is not of three or more previous preterm but single preterm or two preterm births. So in them we have to offer the ultrasound guided surveillance. And if we find that along with the history of one or more, I mean less than three preterm births, then if there is cervical length less than 2.5 centimeter, we can very well offer her the cervical cerclage, that is ultrasound indicated. Third option, a third thing is that if it is incidentally identified short cervix, there is no high risk factor. In incidentally identified short cervix, there is no indication of giving a advantage of cervical cerclage. Then, in a woman with previous unsuccessful transvaginal cerclage, like a cerclage has been put, but still she had a loss, then next time in her counseling also and in for explaining also, she can be offered the transabdominal cerclage, may be discussed and considered. Okay, and so this is the another scenario. If previously unsuccessful transvaginal, offer her transabdominal. If she refuses, then you can offer the transvaginal again. Okay, so in women with singleton pregnancy, insertion of emergency cerclage. Now this is the emergency condition. So we have three kind of cerclage: history indicated, ultrasound indicated, emergency cerclage. In the situation where there is the patient is in labor and the bag of membrane, you know, she has a bag of membrane in the vagina, in that situation we can offer her emergency cerclage, and this says that it delays the labor by approximately average of 34 days, from 18 to 50 days period is there, and average is 34 days compared with expectant management or bed rest alone. So emergency cerclage give the benefit of an average of delaying birth by 34 days. Okay, this is a question in part 2, and it may also be associated the with a twofold reduction in the chance of birth before 34 weeks. So they says an average delay of birth is 34 days. Okay, and twofold reduction in the chance of birth before 34 weeks of gestation. So this also you need to remember. And then the choice of technique. It depends upon the discretion of the surgeon, but the cerclage should be placed as high as possible. So this is the guideline which says that it should be as high as possible. You do McDonald stitch, you apply Shirodker, you do transabdominal. It is upon the surgeon's skill, but it should be as high as practically possible. Now, am I clear till this point? And I would like to move on to the details of the guideline now. So, in this situation, coming on to the definitions, as I've already told you, previous terminology of cervical suture or cerclage can be ambiguous, so more appropriate nomenclature based on the indication is recommended now. Okay, like history indicated, that is prophylactic. Okay, it is a prophylactic cerclage which increases the risk of you know insertion of a cerclage as a result of factors in the woman which increase the risk of spontaneous miscarriage or losses or preterm birth. History indicated when it has to be performed, that you should know. It should be performed between 11 to 14 weeks. Okay, and what should be the requirement for that? We should have a dating scan, we should have a screening test, anomaly screening test of the first trimester, like dual screen test. Okay, and then coming next, and when do they call preterm birth? Before 37 week, we all know. So, ultrasound indicated cerclage, second one. It is a therapeutic one, okay? In this, cervical length shortening, if it is on transvaginal ultrasound, along with the risk factor in the woman, like one previous preterm loss or two previous preterm losses in the second trimester, specifically minded that it is for the second trimester. Then it can be performed on asymptomatic woman also, but she should not have exposed fetal membranes like in emergency cerclage. Okay, so when to do it? See, woman is having a history. Okay, and we want to assess her for applying the cervical cerclage because we want to give her a benefit of if she has a short cervix. So we should offer her ultrasound, serial ultrasound surveillance. That when should it start? It should start between 14 to 24 weeks. And when should and by transvaginal ultrasound with empty maternal bladder. So you have to remember three things here. It is a therapeutic one. It is to be done in asymptomatic women between 14 to 24 weeks. TVS scan is to be done with maternal bladder empty, because if bladder will be full, it will push the cervix upward and wrong estimation of the cervical length can be made. And the third is emergency cerclage. So the important part is duration there. Like in history indicated, it is to be applied between 11 to 14 weeks. In ultrasound indicated, the surveillance should be done between 14 to 24 weeks. And similarly, the suture should be applied between 14 to 24 weeks. Okay. Emergency cerclage. It is also known as physical examination indicated or emergency cerclage. In this situation, it is a salvage measure. Salvage measure in the case of premature cervical dilatation with exposed fetal membranes. Okay, she is not having a complaint of pain in abdomen, but there is a cervical dilatation and fetal membranes are there. So in that situation, you can offer her emergency cerclage. And what symptoms patient may have: vaginal discharge, bleeding, or sensation of pressure, but not pain. Okay, it can be considered up to this duration is a must to remember for any exam going, that is 27 weeks 6 days. Okay, and now coming on to the type of cerclage operations. One is McDonald that we all do in our practice. This is a purse string, transvaginal purse string suture is placed. Whether you put single purse string, whether you put two purse string sutures, there is no data on evidence that which one is better. So you can apply any one. Okay. Purse string suture placed at the cervical isthmic junction, cervico-isthmic junction without bladder mobilization. So this is the difference between McDonald and Shirodkar. In Shirodkar's operation, high transvaginal cerclage. Okay, so when this is transcervical, it is McDonald. High transvaginal cerclage is it required bladder mobilization, because you can't go high up in the cervix without mobilizing the bladder. So it allow insertion above the level of cardinal ligaments, and cardinal ligaments are, another name is transcervical ligaments. So it is again at the level of, isthmus. So that is cervicoisthmic junction. This is also slightly above the cervicoisthmic junction, and to reach that level, we need to mobilize the bladder. Then coming the transabdominal cerclage, one goes through the abdomen via laparotomy or laparoscopy, and suture is to be placed at cervicoisthmic junction. And here bladder should be pushed down. Another type of cerclage is occlusion cerclage. It is, multiple sutures, non-absorbable, either silk or proline, that we apply on the external os. And why? What is the benefit of occlusion cerclage? The theory is the potential benefit of occlusion cerclage is retention of the mucus plug. Just a second. Yeah. Okay. Yeah. So occlusion cerclage, the potential benefit of occlusion cerclage is retention of mucus plug. Means if there is cervical dilation, then the mucus plug it comes out from its normal position. Okay, and then what happens? There is increased incidence of having ascending infection and further preterm labor. So occlusion cerclage, along with providing a structural support to the cervix in the lower part, it also retains the mucus plug. Then when should a history indicated cerclage be offered? A history indicated, which we read just now, in three or more previous preterm births. Okay, in them we should offer a history indicated cerclage. Then it should not be routinely offered in less than previous three preterm birth or second trimestral losses without additional risk factor. Okay, and if she has complaints along with a history of previous adverse event, like she has painless dilatation in the past pregnancy, rupture of membranes, or any lead surgery or cervical surgeries in the past. So still the I know in the past pregnancy, if all this has happened, then it is no criteria for offering her a history indicated cerclage. So it should be offered in three or more previous preterm births. That's it. So, and also, though there is no evidence to suggest an effect on perinatal death, but the author of this GTG, they concluded that cerclage probably lead to a reduced risk of perinatal death when compared to no cerclage. And neonatal morbidity was similar with or without cerclage. So it reduces the perinatal death, the cerclage. So this is new in this guideline. The question can come. And neonatal morbidity was similar, so there is no effect on neonatal morbidity, but perinatal mortality is reduced. So this is to be noted. And another thing is, um, the risk of preterm birth before 33 weeks of gestation is being halved when the cerclage has been applied on the basis of history. Okay, so this can also be important in the exam. Like it reduces the risk of having a preterm birth before 33 weeks to half. And if that we will come on this later, though this analysis suggests that no benefit of history indicated cerclage in women with previous cervical surgery or uterine abnormality. Means the factors that put the patient on risk of having a preterm birth, like having a known Mullerian anomaly or having a previous surgery like LEDs, which or a cone biopsy, which removes the extra cervical tissue like more than 1 centimeter. So in them, a subgroup analysis have suggested that it offers no advantage. Okay, now ultrasound indicated cerclage. In this they say, and remember this, that this all is for singleton pregnancy we are talking about. Okay, this and we have already discussed this, that if it is less than three pregnancy losses, we can offer her cervical screening, serial ultrasound screening, and if it is less than 2.5 centimeter, we can offer the patient the benefit of cerclage. Okay, and if it is more than 2.5 centimeter, then and no other risk is present, then it is not advisable. Routine surveillance of women at low risk is not recommended by the National Screening Committee. So coming on to the next recommendation set, that if women with a singleton pregnancy and a history of spontaneous second trimester loss or preterm birth, if it is one or more who are undergoing cervical surveillance, less than 2.5 centimeter cervical length, or less at gestation less than 24 weeks, okay, in that situation, an ultrasound indicated cerclage is not recommend in that situation ultrasound indicated cerclage is recommended. But if there it is the length is the same, okay, cervical shortening is not there, but funneling of cervix is present, on the basis of funneling we do not recommend ultrasound indicated cerclage. So this you have to note down, that cervical length screening with ultrasound, and if we found funneling, ultrasound indicated cerclage is not recommended. Okay, and coming on to the, so the time period for the screening we have already discussed. What is the time period for the screening? This is 14 to 24 weeks, and of providing the cerclages 40 is also the same. Okay, so coming on to the next recommendations, um, who should be offered serial sonographic surveillance with a view to ultrasound indicated cerclage. So here we have already read it multiple times now, that history of spontaneous second trimester loss or preterm birth who have not undergone a history indicated cerclage may be offered serial sonographic surveillance. as those who experience cervical shortening may benefit from ultrasound indicated cerclage. 40 to 70% of women maintain a cervical length of more than 2.5 centimeter before 24 weeks of gestation. Okay, even if with the history of second trimester loss and spontaneous preterm birth, 40 to 70% will maintain this length. So it is always a good idea to have a serial scanning rather than offering directly the uh, cerclage. That's why we offer in less than 3 preterm losses the ultrasound screening. Now, coming on to the, this is a very important part of this guideline which has been added, that there are some risk factors. On the basis of these risk factor, a woman has been classified in high and intermediate risk groups, and it is according to the Saving Babies Life Care Bundle. In that, there are some risk factor which indicates the ultrasound surveillance of cervical length, and when and how we should perform it. It is mentioned here, and this is very important as well. Women at high risk, which are the women who are at high risk of having a preterm birth. So in this, those women with previous preterm birth or second trimester loss. Okay, this is for ultrasound surveillance of cervical length. So, high risk women include previous preterm birth or second trimester loss between, the lower limit for the loss is 16 weeks, upper limit is 34 weeks. Okay, and we do screening between 14 to 24 weeks about the cervical length. And in the women who have previous preterm loss between 16 to 34 weeks, previous PROM at less than 34 weeks. Okay, previous history of PPROM at less than 34 weeks makes the woman high risk, and we should offer her ultrasound surveillance. Previous use of cerclage, non-uterine variant, if she had previous use of cerclage and there was a successful term pregnancy, in the next pregnancy it makes her high risk for that this pregnancy, and she should be offered ultrasound surveillance of cervical length. Non-uterine Mullerian anomaly variant means Mullerian anomaly, and any intrauterine additions, history of trachelectomy in the past, like CA cervix, that makes these all are the high risk factor. So these are the 6 high risk factors: previous preterm birth or second trimester loss, previous PPROM less than 34 weeks, preterm loss is also less than 34 weeks, and between 16 to 34 weeks, previous use of cerclage in past pregnancy, known anomaly, and history of trachelectomy, also the intrauterine additions. Now, in these women, that Saving Babies Life Care Bundle, they suggest how to do the ultrasound surveillance in these high risk women. They says that these women are to be reviewed by preterm prevention specialist by 12 weeks. Okay, and where possible, or with the dating scan, whichever is sooner. Either if the patient has come for the dating scan and we see it, we will directly refer her to the preterm prevention specialist or the obstetrician who is who has special interest in the in managing the preterm labor, and offer transvaginal cervical screening as a secondary screening test every 2 to 4 weekly between 16 to 24 weeks. So this is just similar which we have read till now, like whom to offer ultrasound surveillance screening and how. So it should be offered between 16 to 24 weeks, and it should be offered 2 to 4 weekly. These all are one liner questions in an SBAs in part 2 exam, and also once doing the counseling of patient in part 3, you should know these liners, that this patient is a high risk patient and we should offer her cervical screening every 2 to 4 weekly between 16 and 24 weeks. Now there are other set of women who are intermediate risk, and we have not talked about them yet previously in this guideline. The intermediate risk group include previous full dilatation cesarean section. Okay, previous fully dilated means second stage cesarean section is also put the woman at intermediate risk of having a preterm delivery in next time, and we can offer her ultrasound screening surveillance, or there is a history of leads with an excision depth greater than 1 centimeter, or more than one procedure of leads, or a cone biopsy. These factors, in which we have already discussed that there is no significant evidence about them, the Saving Baby Life Care Bundle, they have put these women in the intermediate risk, and they says that these set of women, they should at least be offered a single transvaginal scan between 18 to 22 weeks. Here it was 16 to 24 weeks for a longer time, and repeated 2 to 4 weekly scans. Here a single scan between 18 to 22 weeks as a minimum. Okay, so this is they have added. And however, they says that with these risk factor, all the risk factor other than having a this single risk factor of having a previous preterm birth or second trimester loss, all other factors, there is no stronger evidence or uncertainty as to how to care for these women. Even if they in this care bundle they have described this, still we are not certain whether to offer this or not. Okay, but we can always give the evidence in structural discussions or in question answers. We can always use these as evidence that how to manage them. So we can offer an ultrasound indicated cerclage, and here it is written it may be considered in them. In all other people, this may be considered. So, as we know, again, in high risk women, in the first group of women with previous preterm loss, we have to do cervical screening as ultrasound cervical screening between 16 to 24 weeks, every 2 to 4 weekly, and we can offer this cervical cerclage in them if the cervical shortening is there. But rest other with PPROM less than 34 weeks, previous cerclage, Mullerian anomaly, intrauterine adhesion, trachelectomy, they all, if we have to offer them cervical screening, then we should offer them with this protocol. Okay, same protocol as we are offering to the preterm loss patient. And some women who have previous full term dilatation, they are also at preterm risk, so we can offer them at least one cervical screening. And the women who have leads more than 1 centimeter depth or repeated leads or a cone biopsy, and if she becomes pregnant, we can offer this group a minimum of one scan between 18 to 22 weeks. See, time difference is separate, and time duration is different, and the recommendation is different. Okay, but still they say there is uncertainty on how to care for these women. But if question answer come, you have to reply like this, and if in viva it comes, then you can give this reference also. Now coming on to the multiple pregnancies. So in this, this says that all these recommendations which we have discussed till now, they are not applicable if the woman is having multiple pregnancies. Okay, the decision has to be made on the basis of the current pregnancy situation, because no study proves that even if woman has three or more preterm birth, and we are offering her history indicated cerclage in this pregnancy when she is pregnant with multiple pregnancy, then there is no evidence that it provide benefit to the woman in in having a reduced rate of preterm birth. Okay, so in multiple pregnancy, this history indicated or ultrasound indicated doesn't imply. So now there are certain important things, that there is a meta-analysis which has which has evaluated the efficacy of progesterone, pessary, and cerclage, and they have shown that meta-analysis has shown that no intervention significantly reduced the risk of preterm birth at less than 34 weeks or 37 weeks or neonatal death. So nothing is beneficial in twin pregnancy. And if you can be asked about this trial, this is a stop pit. 2, it's a RCT on the Arabian pessary. It's kind of a, plastic pessary to prevent the preterm birth in twin pregnancy. So, I can show you the picture of the pessary. I have taken one picture of this is the Arabic pessary. So stop it trial is going on. This kind of pessary, it is to be it is being put once she's pregnant, once the woman is pregnant at around 14 weeks, and then it is removed at 37 weeks. What does it do? Like normal pessaries in gynae, it supports the cervix and keep the pregnancy at place like a cervical cerclage. So these kind of trials are going on to see whether they are effectively doing it, or beneficial. So the results are yet to come, and moving ahead. So in twins, it is not applicable, this guideline. Coming on to the cervical surgery, trauma, and uterine anomalies, we have already discussed in detail that when the history or ultrasound indicated cerclage role is uncertain in other high risk groups who displays no additional risk factor, such as women with Mullerian anomaly, previous cervical surgery, or multiple dilatation and evacuation. So, in them, we can very well say the role of ultrasound indicated cerclage or history indicated, like they have anomalies, they have previous suction evacuations, they have previous cervical surgeries, we are uncertain in providing this. Okay, but according to live baby birth care bundle in UK, these women are being put in the intermediate risk, and one scan can be done in the cervical surgery patients, um, in between 18 to 22 weeks, and then if, according to the cervical length, depending upon the discretion of the obstetrician and also in consultation with the mother, that can be decided whether to put a cervical cerclage or not. So like this we have to take other things and present it before the examiner, before the patient in role player station. Okay, and we have already discussed about the leads, about the cone, like between 18 to 20 weeks we are going to offer a single scan, transvaginal scan. Okay, and no uterine variant should be preferred to a preterm prevention specialist, they should be referred to. Now, there is additional recommendation. If the woman who is having raised BMI, so the answer to it is in any number of BMI, like if she has mild, moderate, morbid obesity, the cerclage will be effective. Okay, in women with raised BMI. So cerclage will not be like you can't tell the patient that it is not recommended, or it is less effective. Will be same effectiveness will be the same, and BMI will not affect it. Coming on to the transabdominal cerclage, transabdominal, when to do it? As I have told in the beginning itself that it should be on the discretion of the surgeon how they want to put the cerclage, but transabdominal preferably should be given to the woman who has previous unsuccessful transvaginal cerclage. Then the next step can be transabdominal, but at the same time it should be discussed, and it should be the decision of the surgeon, and also the like in which the surgeon is confident enough. Okay, if surgeon doesn't want to apply transabdominal cerclage, it is better that going again for a transvaginal or high transvaginal uh, cerclage in a patient, in a woman who has previous failed transvaginal cerclage, like previous preterm birth despite of having a cerclage. Okay, so when should the cerclage be applied? There are two time intervals in which it can be applied. One is in between the pregnancies, that is interval transabdominal cerclage, that's preconceptual, and in early pregnancy also it can be applied. It can be applied both ways, laparoscopic and laparotomy. No method is superior to each other. But laparoscopic approach is having fewer complication, but only to be done with a suitable surgical expertise. Okay, so no one is superior to another. So we have to weigh according to the surgical expertise. Nowadays, we all know robotic surgery is also coming up. Um, so the, robotics abdominal cerclage has also been applied. Further studies are needed to assess its efficacy because it is just we can say that it is in streamline from last 1 or 2 years only, like it is coming up so nicely, and people are trying the technique in their practices. So we need further evidence, and few more years I think that will take to gather the evidence. Now, what if you have applied the abdominal cerclage in a mum and she get the delayed miscarriage or fetal death? In that situation, a senior obstetrician should discuss the options with the woman because it is a detrimental, like it is psychologically, physically, it is very difficult for a woman who has undergone previous miscarriages also, or bad history, or having risk factors. We have applied abdominal cerclage in the woman, and now fetal demise has happened again. So after that, complete evacuation, suction and evacuation can be offered without removing the stitch till the age of 18 week of gestation. So this is a must to remember point for the part 3 and part 2 both, that 18-week gestation is the limit for suction and evacuation. Curettage can be done up till 18 weeks of gestation. It can be performed, okay? And if required after this duration, suture, if the demise is after this duration, women will be given an option that suture may be cut from, by going into posterior colpotomy will be done and suture can be cut. If this is not possible, because transabdominal is quite high up and it is very difficult to cut the stitch, if it is not, it does not happen, to avoid cervical injury, uh, what can be offered is hysterotomy. So before taking the patient for the posterior colpotomy, you have to tell her that if that is not possible, hysterotomy is the option for you, or the cesarean section may be necessary. The woman's decision should be aided by senior obstetrician. So we all know this 18-week cutoff now, okay? And other option is posterior colpotomy after 18 weeks, to cut the stitch. If that fails, hysterotomy, or later pregnancy, cesarean section, right? Now emergency cerclage, few points very important. So a balance should be made whether we shall apply it or not. That it can prolong the pregnancy to a bit, but not too much. Average is 34 weeks, and twofold reduction in the delivery before 34 weeks, in less than 34 weeks. So we have to weigh that we are pulling up the pregnancy, like if the fetus is say 18 weeks, okay, and woman has this bag of membrane inside the vagina, and we put the emergency cerclage. In that situation, we can prolong the pregnancy to more, we can stretch it out to 22 weeks, or 24 weeks. And now if baby delivers, the complications and the neonatal morbidity and survival of the baby, increased risk of cerebral palsy, um, and burden on the parents, that all is to be, and the long term mental and physical and behavioral problems, those all should be weighed and discussed with the parents and also with the neonatologist. It should be a combined decision, okay? So it should be weighed against neonatal morbidity and mortality, against the possibility of prolonged severe neonatal morbidity in a baby that might otherwise die, and approximately it increases the duration to 34 weeks, and the confidence interval is 18 to 50 days, minimum 18 days, maximum 50 days. Now this all we have, now what is the cervical dilatation limit on which we should perform this? So see, if there is a bag of membrane, then it should not come out of the external os. Okay, if it is and if you are able to assess the cervical dilatation, it should be less than 4 centimeter. So these are the two things you should know. Okay, but because if it is more than 4 centimeter and membranes are coming out of the external os, it is associated with high chance of cervical cerclage failure. So this is again very important. You should remember it by heart. Contraindication of every procedure we should all know. Like when you will not offer, if she is in active preterm labor, we are offering this to a woman who is having painless painless pressure, or um, the woman is having a pressure sensation down below, and there is no active preterm labor, she is not having pain. So active preterm labor start from more than 4 centimeter, and according to WHO it is more than 5 centimeter now. So she should not have active preterm. She should not have any chorioamnionitis clinical evidence. Okay, continue. No vaginal bleeding should be there. Spotting can be there when the cervix is dilating. It can be show, but the continuous vaginal bleeding should not be there. PPROM shouldn't be there. Evidence of fetal compromise shouldn't be there. Lethal defect shouldn't be there. Fetal should not be there. Okay, so labor, infection, leaking, bleeding, fetal defects, fetal compromise, death, they should not be there. And what information should be given to women before cerclage? Every woman should be having a verbal and written information. She should be told that small risk of having injury during the procedure. There is risk of injury to bladder, cervix. Okay, the membranes may rupture, and there can be bleeding post-operatively. So, and if you go in labor and stitch is still in situ, then there is chance that cervical laceration or trauma can happen. So these are the risks which are nominal with the procedure. Like this is the procedural risk, not that this cervical injury, this cerclage is causing anything like this. Like it is not associated with PPROM. Like if you have put the cerclage, patient is having a cerclage and she undergoes a labor, or she acquired an infection, or she had a leaking before labor, that is not caused by cerclage. So you have to tell her that the risk, whatever I am telling you, will be now. The future risk is not because of the cerclage procedure itself. And um, induction of labor, cesarean section, this all nothing related to cerclage. You put the cerclage, you forget it. But if you go in spontaneous labor, there are chances that laceration may happen, so you have to come as early as possible, um, if the cerclage is still in situ. Okay, otherwise the cervix will get tear off. So this you have to explain the woman that cervical suture is not associated with increased risk of preterm birth or second trimester loss, like nothing doing with any complication. It is only on the spot things which will happen. Later on, it will not cause anything else. You have to explain it, speak it to the woman. Okay? Cervical cerclage may be associated with the risk of laceration or trauma if there is spontaneous labor. So this is all for the non-emergency cerclage. Now, what is the investigation required? As we discussed in the before, that the investigation required are in first trimester when we are doing it history based, we need first trimester ultrasound scan and screening for aneuploidy, like dual marker test. Why? Because at that time we are doing it between 11 to 14 weeks. So we should have only these many things. And if it is ultrasound indicated scan, that is between 18 to 24 weeks, right? So at that period of time we should have a anomaly scan which is to be performed. So in ultrasound indicated, what investigation we shall have? It should be anomaly scan. We should have that because the screening is done between 16 to 24 weeks, and ideal time is also between 16 to 18 weeks of performing this scan. Now this says Uh, sorry. Yeah. Is it required, like if we are going for any emergency cerclage or any if we are going for emergency cerclage, woman is having this bag and we can suspect that she is in preterm labor, so do we have to do this WBC count and C-reactive protein to detect chorioamnionitis? Then the evidence suggests that overall clinical picture is the one which matters the most. If you find she is having labor, if you find she is having clinical sign of chorioamnionitis, that makes it a contraindication. You should not waste any time in getting the WBC and CRP. Okay, so emergency circulage should not be delayed for the reports. It should be the overall clinical pictures that matter. So now you can perform it if you find that woman is fine. She's not having any tachycardia, hypertension, any fever, any uterine tenderness, any foul smelling discharge. You can go with the uh, emergency circulage. Now, amniocentesis, is it required to do amniocentesis before rescue, like emergency circlage is rescue circlage or ultrasound indicated circlage? So they says there is no clear cut evidence, no data demonstrating improved outcome. But yes, if you feel that she has clinical uh, signs of chorioamnionitis or symptoms indicate that, in that situation you can take intraamniotic fluid to rule out infection in that, because if it is the infection which has come to the amniotic fluid, then the outcomes for the fetus is really poor, and it will aid in the decision making for emergency circulage. All right, so you have to use this guideline or evidence for your clinical practice. Okay, amniocentesis, because question can come from this. Amniocentesis before emergency cerclage does not appear to increase the risk of preterm birth before 28 weeks. But there is likely to be some risk to from the procedure. And we know it all that amniocentesis have its own risk of abortion, of pregnancy loss, zero point 0.5 in 100 fetus can be lost. Okay, and in 20 less than 28 weeks we can perform the amniocentesis up till 28 weeks for the diagnostic purpose, for the infection diagnosis, and the risk will be from the procedure. It will not increase the risk of preterm birth. And is amnio reduction before emergency cerclage recommended? No, no to any of these ideas. Should a latency period be observed between presentation and insertion of a rescue or ultrasound indicated cerclage? Each case should be managed on an individual basis. Like if she comes in emergency, you don't have any option, you do not wait for any latency period, you will just take the patient to the OT and apply it. On ultrasound indicated, it should be done on an elective basis. Yes, and if she doesn't have any anomaly scan, we will first get the anomaly scan and perform it, right? So we will fulfill these criteria and we will be managing each case according to our discretion, our judgment. Okay, so routine genital tract screening is not to be undertaken before the cerclage, right? So, but if the patient is having a discharge, like infective, any infection is there in the genital tract, that swab shall be taken, and the antibiotic should be advised to the patient or given to the patient according to the culture reports. And microbiology team should be involved in that. We all know that it is always multidisciplinary. Tocolysis is not considered routinely after the cerclage, and it should be considered on the individual basis. Like if it is an advanced pregnancy, emergency cerclage is there, and there is a risk that patient woman can go in preterm labor from now, then you can provide tocolysis. Otherwise, routinely it's not advisable. Should perioperative antibiotics be given? That's again the discretion. Like if it is an emergency cerclage or she had a high leak, any history of having, you know, vaginal discharge, in that situation we can provide the antibiotics, otherwise not. So, which anesthetic should be given? Generally, we do in OPDs, not in OPDs, like we do in our practice. Um, we give regional anesthetic, but this says that both regional and general are safe. Okay, and when to do and how to do elective transvaginal cerclage will be a daycare procedure. That is to be that is to be told to the woman that it is a daycare procedure, and we can anesthetic team will decide about the anesthesia. So like this, you will give the option to the woman. And which suture is to be used? It should be a non-absorbable suture. We use silk routinely, but proline can also be used. And the choice of cerclage, it will depend upon the surgeon, but it should be as high as practically possible. One or two per string, use anything. Cervical occlusion suture in addition to the primary cerclage is not routinely recommended. Okay, cervical occlusion suture has the benefit of retention of the mucus plug. We have already discussed that. Yeah. So bed rest, it is not advisable to all the women. So that is to be seen according to the circumstances of the woman. Otherwise, it is not recommended routinely. Okay. Sexual activity, intercourse, no need to advise abstinence to the woman for any number of weeks. Evidence suggests that it does not. Uh, the no study evaluate the effect of sexual intercourse on the risk of second trimester loss or preterm birth in women with cervical cerclage. Then they say, is there any role of post-circulate serial sonography in surveillance of cervical length? For that situation, there is only one point which is important, that routinely it's not advisable, because once you have put the cerclage, what else we can do? We can't do anything now. So they says, but in the ultrasound indicated cerclage, you you can screen the woman for the cervical length. Okay, so in this situation, that will if the length is decreasing, right, that means woman may go in preterm labor soon. So in that situation, we can offer the steroids to the woman, or if the length is really less, we can offer her in utero transfer in emergency cerclage situation. Okay, so this is the only beneficial point. Like in ultrasound indicated cerclage, yes, you can offer the serial sonographic measurement. Otherwise it is not recommended to provide the steroid administration. And in utero transfer, there is a role, otherwise there is no role. Now fetal fibronectin testing, it is not advisable post cerclage. Okay, and should women receive supplement progesterone following cerclage? It is not recommended. If you put the cerclage, then do nothing. And there is no evidence that progesterone or Arabian pessary alone are more or less effective than cervical cerclage. So cerclage is to be given on for different scenarios, for different indications. Now, when should it be removed? Between 36 plus 1 to 37 week of gestation. And if it is unless the birth is by pre-labor cesarean section, in which case suture removal could be delayed until this time. Okay, so in pre-labor cesarean section, we can delay the cerclage removal. Otherwise, we should be removing it between 36 to 37 weeks of gestation. And it should be before labor. And once the patient, if she comes before this period, less than 36 weeks in labor, then we have to remove it immediately. So, a high cervical cerclage, that's the Shirodkar. It require anesthesia for removal. The McDonald one, it doesn't require any anesthesia. You can simply do it in the uh, examination room. And transabdominal cerclage require birth by cesarean section, with the abdominal suture may be left in place following the birth. It is not required to remove the suture. So, if it is PPROM between 24 and 34 weeks, mind it, it is very important to know that if the PPROM is between 24 to 34 week of gestation and without evidence of infection or preterm labor, right? Delayed removal of the cerclage for 48 hours can be considered to facilitate in utero transfer. So, if she has pre-prom, should you remove the cerclage Instantly? No. Because see, 24 to 34 weeks, the fetus can be benefited if the PPROM, if it is a high leak, or we give antibiotics, we observe the patient until unless she goes in labor. So if there is no evidence of infection or labor, we can withhold the removal of cerclage, okay, at least for 48 hours, or for intrauterine transfer. Now, another thing is, if the gestational age is less than 23 weeks, or in which the viability as such is very difficult to say, and after 34 weeks it is a good prognosis for the baby. So minimal benefit is 48 hours after PPROM, and suture removal can be done anytime, even before 48 hours also it can be done. So there is no minimal period for this, okay. And it shows that delayed suture removal, like more than 48 hours, does not offer any benefit in both these situations. So this is also important to remember. So that's all about the guideline. I hope I made it understandable for all of you, and I wish that you will go through it once more. And I don't think that there is any other question other than the highlighted points in the past papers as well. So I hereby end this. I will be sharing this video in the group as well. And there is like, yeah. I am for the MRCOG Part 2 aspirants and Part 3 aspirants. I am starting a fast track guideline revision course. It will be a 4 days rapid session course starting from 1st till 4th, and the timing will be 12 p.m. Indian Standard Times. And I would cover more than 35 guidelines in the same way as we have covered today. And it will be a quick glimpse of the clinical blend also of the guidelines. And I hope that will benefit you all, and you will be able to brush up your memory of the guidelines before the exams of MRCOG Part 2, and also for Part 3. This is equally important. So if anyone is interested, you can contact. I'll be putting this in the group also. So we will book the slots, and there will be not more than 8 to 10 candidates in a group, because we will be having an interactive discussion also about the guidelines, whatever we will be doing. Okay. So thank you so much for attending the class, and I'll end the class now. If you have any question, you can ask. Thank you, Kirti. Any questions, anyone? Anam, Manikam, any questions? Okay. So then I end this meeting. Thank you again.